Hello guys, hope I'm audible and visible. If so, just give me a hi, thumbs up, good evening, and welcome to the new week. I'm going to start with pathology this week. You guys had pharmacology starting the last week, and it'll be a rotation so that you don't get bored once with one subject, and it'll be equal spacing of everything, right? So just to start with, did you guys had time to read whatever we learned last week? Yes, no, maybe a little. Anyone? Okay, I'll let my live stream start for me. I'm not able to see the comment. Just give me a second. Right? So if you've gone through whatever we saw last week, that's cellular adaptation, cell injury, necrosis, and all of those, we will go with whatever topic you can see here today. We'll be talking about intracellular accumulation and apoptosis, right? Apoptosis is the physiological form of cell death, and intracellular accumulation obviously is the intracellular accumulation or the intercellular accumulation, right? Ignore that part. Okay, can you guys see me? Am I visible? Uh, I'll just call it active. Am I visible first of all? Because for me, I cannot see my video. Great. Okay, great. I think I'm visible. Am I audible and visible? Just say a hi. Okay, great. Thank you. Thank you, guys. So if you have read pathology, amazing. So the tech is back and we didn't waste much time this time, right? So if you have done with cellular adaptation and if you are done with necrosis, today what you're going to see, as you can see, we're going to discuss about apoptosis and about intracellular accumulation as well, right? So intracellular accumulation is intracellular accumulation, not an intercellular accumulation. Lay the spelling mistake here, fine. So today's class will be covering these two competencies. Right. So we have multiple competencies. I'm going as per your CBME curriculum so that we'll make sure everything is taken care of, right? Okay, great guys. We'll be discussing about the pathological features of calcification. That will be in the intercellular accumulation. We already know about gangrene. See, in CBME curriculum, they have linked few things. We learned about gangrene and necrosis, so I'm not going to talk about gangrene. We'll talk about other intercellular accumulation, fats and proteins, and also obviously we'll be talking about apoptosis. In your CBME curriculum, in the competency, apoptosis and necrosis is put together, right? We'll be discussing about apoptosis and all these about the intercellular accumulations, right? Okay. Now, see, I always insist on having your basics extremely strong. Everything in medicine is in the name. If you can catch the name correctly, if you can understand the name correctly, most of the problems in medicine is solved. It's not apoptosis. You must have been read. You must have read them for sure as apoptosis, right? When I was in second year, I also read them as apoptosis only, right? So it's apoptosis. So you must wonder what does it mean? Like, does it make any difference? Ptosis. you will learn when you come to ophthalmology in the next year. Ptosis means drooping of eyelids or falling. This word apo, I'm sure you must have heard, right? In your biochemistry, have you heard about apoprotein, apolipoproteins? Yes. So apo means precursor. That's what apo means. So when I say something as apoptosis, this means I'm going to learn something which is going to be seen, or it's a precursor to a cell falling down or a cell dying, right? Ptosis means it's falling down, right? A precursor to a cell falling down is called as an apoptosis. That's all. It's everything is in the name. Like you guys already know, apoptosis is definitely a physiological form of cell death. Right? We had a discussion last time, which is bad, necrosis or apoptosis. Do you remember the discussion? If you remember, just can you comment which is bad, necrosis or apoptosis? Apoptosis is bad, right? So apoptosis is physiological. That is very, very good for us. But when apoptosis becomes pathological, that is again bad for us, right? So I'm sure you must have heard about other name of apoptosis, programmed cell death. We'll see why it is called programmed cell death. We'll see everything required for us, right? Like we already know, apoptosis can be both physiological, okay, and apoptosis can also be pathological also. It can be both physiological and pathological. Like any other form of cell adaptation or your cell injury, it can be both physiological and pathological, right? Perfect. Right? Just cell death, that's all. We will go to the examples of apoptosis. I will divide apoptosis into physiological apoptosis and pathological apoptosis. Pathological apoptosis, there are few groups of disorder which will go to apoptosis. We'll read them for sure, fine. So when we read about atrophy, right? When we read about atrophy as a cellular adaptation is a gross terminology or a microscopic terminology? Gross or microscopic? Just comment G or M, that's enough. It's a gross terminology, right? Apoptosis is a microscopic terminology. If you're asked in a viva, like define apoptosis by definition, it means it's a pattern of microscopic cell death. That's all. It's nothing but a microscopic cell death. There are two major patterns of microscopic cell death. One is necrosis, the other one is apoptosis, fine? Just two patterns of microscopic cell death. This is one of the pattern which is more physiological and also pathological, right? Let's go to examples of apoptosis. We already know quite a few examples of apoptosis because we know already atrophy. So whichever we read in atrophy, some of them, especially which is irreversible, will definitely come into apoptosis. The thymus atrophy, reversible, irreversible? Irreversible, right? Endometrial atrophy after hormonal loss, reversible, irreversible? Irreversible. There are multiple things which are irreversible atrophy. All of the irreversible atrophy in microscopy are examples of apoptosis. We already have an existing knowledge. I'm not going to load you with things. We'll use simple terms, what you know already, to fill the pages. Ultimately, we're going to fill the pages, right? So we have physiological apoptosis and we have pathological apoptosis as well. I'm just going to enumerate few things we actually already know. You need not write all the 6 or 5 examples given in Robbins. If you know few things which you is there in your brain, you put in the paper, that's more than enough, right? So your physiological apoptosis of an embryological problem. Anything embryological, that's going to die by apoptosis. Example, thymus, your thyroglossal tract, we learned about them, right? Everything embryological. I'm just putting it for an example, thymus. Thymus grossly undergoes atrophy. In microscopy, thymic cells will undergo apoptosis. That's the only difference between atrophy and apoptosis, right? Second thing, can anyone tell me what is the use of thymus? Since we are in thymus, I'm going to take that only because it's always comfortable when you link things, right? What is the use of thymus? You must have read in your physiology itself, right? Thymus helps in the development of T cells. It teaches to my lymphocytes which is self antigen, which is non self antigen. Just I'm giving you a random example. Let's assume I'm having a self antigen. In when it was developing, we had a self antigen, and one of the lymphocytes was destroying the self antigen. This lymphocyte is good or bad? Just comment G or B. A lymphocyte which is destroying the self antigen is good for the human being or bad for the human being? It's absolutely bad, right? So thymus removes them by apoptosis, right? So there's a phenomenon called as negative selection. I'm sure you must have heard this term for sure. Negative selection happens in the lymphocytes of thymus, right? So the lymphocytes of thymus, the negative selection, that's this lymphocytes against self-reacting antigen will be removed by apoptosis in the thymus, right? Perfect. That's the second example. Already you guys know. Third example. I'm just going to give you very simple examples. Let's assume you got a streptococcus infection in your skin, random infection. Neutrophils comes outside, kills the streptococci. Tell me logically, should the neutrophil die there or should it go back into my bloodstream? It came out of the bloodstream, destroyed the organism. Should it go back inside, or it should die there itself? It should die, right? It's not useful for me for a used neutrophil or lymphocyte or any WBC to go inside, right? Secondary to inflammation. In other words, post-inflammatory cells. Post-inflammation, every cell will die. It has to die by apoptosis. Okay? A few more again physiological things. This I'm sure you can relate. How many of your hostelites? Can you put up your hands? If you're a hostelite or not even a hostelite, day scholar, I'll keep in general medical students. I'm sure quite a few of you must have not taken bath at least once in your first year of MBBS. Yes or no? Be honest. I'm dead sure. Some of them every week, 1-2 days you won't take bath, right? If you don't take bath and if you rub your skin, can you see dirt? That's nothing but dead skin cells. Every day skin cells die. They die by apoptosis. If they die by necrosis, I'll have inflammation. Every day the skin cells die, you'll have inflammation there. It cannot happen, right? It cannot have pain, right? Lots of cells which die by apoptosis physiologically. Example, your skin cells. All the skin cells daily they die. The GI epithelium, daily they die. There are lots of things which die on a daily basis. All of these are physiological cell death. They are old, that's all. It's falling. The hair fall. It might be painful in the heart, but it's not painful in the hair, right? Apoptosis. The hair fall is apoptosis. These are physiological problems. It just dies, that's all. All of them are physiological apoptosis. This is not my concern. This is perfect. My main concern is the pathological guys. The pathological guys are the major concern for me. I'm going to have three major groups of pathological things which will cause apoptosis. The first is virus. The reason why I am putting virus is, though virus is not more important for me, we learned apoptosis how it happens with virus only. We use them in cell culture and we learned every mechanism with the virus. So thanks to the virus. So any virus induced cell death is by apoptosis only, right? Second, any cell which has a DNA mutation, a DNA mutation will induce cell death. Sometimes it might not, right? If it induces cell death, it's by apoptosis only. It's always by apoptosis. That's how DNA mutation happens, right? Third, anywhere I'm having a protein accumulation inside the cell. When you have a protein accumulation, it has a different way of apoptosis, but it also is by apoptosis only, fine. When you have a protein accumulation inside a cell, it increases the endoplasmic reticulum stress. This was a little bit of a new thing, which was there couple of edition before Robbins. ER stress mechanism was not there. So any intracellular protein accumulation, I'll have an ER stress, and that causes cell death. This cell death is also by apoptosis. I'll tell you where it is helpful for me, right? How many of you have heard about Negri bodies and rabies? Yes, you have. That's an intracellular protein accumulation, right? Am I right in calling that? Yes, it is. Prion's disease. You must have heard about Prion's disease, right? Intracellular protein accumulation. So any cell has more amount of misfolded protein accumulating, the cell will die. That's my process. I cannot have more and more and more abnormal protein, because if the abnormal protein, cell cannot function, automatically die, and it dies by apoptosis, right? So these are the examples of major examples for pathological apoptosis. We'll use this and we'll learn them in future for sure, fine? Okay, so we know about examples of apoptosis, physiological and pathological, right? Next thing is, why do I call it programmed? Necrosis was not called program, right? The main reason, I'm sure you must know that this is called as programmed cell death, right? That's one of the first thing you memorize and you will never forget. It's like your mitochondria, power of cell, right? Apoptosis and programmed cell death, no one forgets, but we never learn why it is programmed, right? Most of the things in apoptosis are controlled by genes. That's why I call it program. It's a predetermined set. There's a first step, there's a second step, there's a third step. It happens like that, right? Most of them are under genetic control. That's why I call it a programmed cell death. It's not like necrosis. Necrosis, there was hypoxia, ischemia, sodium potassium ATPase came down. Blood comes properly, sodium potassium ATPase works properly, reversible. It's a very dynamic state. Necrosis goes with the flow, but apoptosis, everything is programmed. The good thing about everything being programmed is I can block it at any point and I can reverse them. That's the best thing about everything which is programmed. 1, 2, 3, 4, it happens. Remove the fourth or block the fourth, nothing will happen, right? So it's under genetic control always. That's the reason I call it a programmed cell death. On the other hand, necrosis and most of the other forms of cell death are not controlled by genes. It's on the flow, right? The other major guy is necrosis. Necrosis is not based on the genes. It's based on the stress. It's a stress-based death. So when I have ischemia, I have a routine pattern of death. When I have some other injury, I have a different pattern of death. That's the reason necrosis is not programmed and apoptosis is definitely programmed. In other words, any cell death which has a genetic control, I'll call it programmed. You must have heard about necroptosis, right? It's also programmed only because it's under genetic control. That's the only reason here. I want you to remember this because we'll use some words as programmed cell necrosis, which means it's a type of necrosis which is programmed. That's why we call it as necroptosis, right? If anything is under genetic control, we can use the term it's programmed. That's all, fine. Okay, so we know why it's called a programmed cell death as well, fine. Now, what is this program which is saying that what all genes or what is the exact template of apoptosis? For any apoptosis, we have two things. I'll just erase this necrosis and the stress-based thing. This is not required for us. Okay, so let's say anything. I have two pathways here. I have something called an initiator pathway of apoptosis. That's the first step. It's initiates, right? Or the initiator phase. In this initiator phase, I have two more subdivisions. I have something called an extrinsic pathway and I have something called an intrinsic pathway. Okay? I have extrinsic and I have intrinsic pathway. So both these extrinsic and intrinsic pathway will join together and it goes to a second phase called as an execution phase. The execution phase is obviously followed by the death, right? I want you to leave some spaces here. If you're writing notes, how many of you really write notes? Can you honestly put up your hands? Because I feel that you guys will be waiting for the PDF. PDF will be there for sure, but please try to write notes, fine? If you're writing notes, leave gaps here because I'll be filling few numbers here. Those numbers are always difficult to remember. More amount of time I write, more places I read, it stays in the mind for a little bit longer time, right? So I have initiator phase, I have execution phase. Whatever may be the stimulus for initiator, it goes into execution only. Whatever may be the intrinsic or extrinsic, it goes to execution only, right? So this is a normal template. Again, leave spaces here. I'll fill a few things here, right? Perfect. Great. Good. You guys are writing notes, fine. Now I'll go to the extrinsic pathway of the initiator phase of apoptosis, fine. So I told three things, right? Three things which are important pathologically which can cause apoptosis. What is the first guy amongst that? Virus. Virus uses this part. Most of the virus-induced cell death takes care of the extrinsic pathway of the initiator phase. See, there are two things here. I'm talking about initiator phase only. In that, I'm talking about the extrinsic pathway, right? So virus-induced cell death is by extrinsic pathway of the initiator phase of apoptosis. Fine, I hope I'm clear, right? Let's say I'm having a cell here, a normal, beautiful cell. Unfortunately, a virus came inside. COVID, it has just kind of toppled us for years together, right? Let's assume COVID came inside, fine. So COVID got infected. This cell got infected with COVID, fine. So this is an abnormal cell. Am I right in saying that every virus in my body is an obligate intracellular organism? If I destroy the cell, the virus also dies, right? That's a simple funda. The cell has got COVID. The only way or the easiest way to destroy COVID is kill the cell. Any virus-induced infection, any viral infection, what inflammatory cell do you think will help or protect me? Lymphocytes or neutrophils or plasma cells? Most of the viruses are held by lymphocytes, right? So this is my virus-induced cell death. So my lymphocyte says that. So the lymphocyte goal here is very simple. Is to destroy the cell. Okay, they have to kill the cell. That is the goal of this cell death. That's all, right? The lymphocytes, we call them as CD8 T lymphocytes. Mamta will talk about that in your immunology chapters. CD8 T lymphocytes will destroy the virus. You must have read them in physiology also, sometime at least. You must have called them cytotoxic T cells. Cell is cytotoxic, is killing the cell. That's the way by which lymphocytes act, right? So the lymphocytes have to destroy it, fine? Perfect, Palival. Okay. So here what happens is, let's assume this is my virus infected cell. Okay. This is a virus infected normal cell. So every cell in my body, not just virus infected cell, every cell in my body has a ligand called as, or a receptor called as FAS. FAS receptor is always there, right? As FAS receptor has multiple other names, CD95. Unfortunately, the CD marker was asked once in an exam. If they ask again, you have to remember them, right? Also, it's a group of TNF receptor superfamily, right? TNF is tumor necrosis factor. That receptor family, this FAS receptor is there, right? FAS is the receptor. FAS is a chemical abbreviation. You not know the abbreviation of it, expansion of it, right? Now, this receptor is there in every goddamn cell in my body. But when virus comes inside, the lymphocyte knows I have to kill. So what happens is these lymphocytes have the ligand for it. This is a lymphocyte. They have the FAS ligand. This ligand binds to the receptor. L stands for ligand, right? I am sure you must have known the definition of ligand right from your first year itself, right? So the ligand binds to the receptor. Anywhere ligand binds to a receptor, the receptor will be activated, right? That's how it is. If the cell is not infected by virus, lymphocyte will never come close also. Nothing will happen. No binding, nothing will happen. Only when the cell is infected by virus, my body knows it's a virus infected cell. Let me go and bind with the lymphocyte and destroy it. So once the ligand binds, it will activate a downstream pathway. That's how every receptor works, right? Activate something called as an FADD. FADD will be activated. FADD stands for FAS. FAS is FAS, associated death domain, right? It's FAS associated death domain. That's the abbreviation for FADD. Again, it's not very difficult to remember. It's a death domain, or just remember FADD more than enough. The purpose of FADD is very, very simple. It does only one thing. It converts one of the important proteins, makes them active. Can anyone comment what protein is involved in apoptosis? There's one important enzyme or a protein which is involved in apoptosis. I'm sure you must have read them, right? You have something called caspase, right? So what happens is these convert procaspase. Procaspase is the inactive form, right? The numbers 8 and 10 into active caspase. Okay? It converts procaspase into active caspase 8 and 10. So ultimately, whatever may be the virus, be it COVID, be it rabies, be it dengue fever, any virus, any goddamn virus in my body, it goes and infects a cell. Lymphocyte will attract them, lymphocytes will identify them, lymphocytes will activate these caspases. The cell will activate these caspases, right? This is what happened. So now what I want you to do is, we left a gap, right? So right here, the caspase number are more important. Just write caspase 8 and 10. See, because these are numbers. If I have an MCQ saying which of the caspase is involved in extrinsic pathway of cell death, you have to know about it. Intrinsic has different caspases, execution has different caspases, right? So we know that this is a caspase. These caspases are activated. Amongst this, I don't know which genius was it. Once it came in exam, which of these is human caspase? Please, I'm requesting you, when you become seniors, when you become consultants, when you become assistant professors and professors in future, you will for sure, some of you at least will, don't ask questions like this. I don't want my future medical, you are the pillars of medical system in my country. I don't want to remember this is an organism caspase, this is a human caspase. But unfortunately, there are few deadheads there. So human caspase is caspase 10. They do ask it. So till they are there, we have to struggle and learn about it, right? Caspase 10 is a human caspase. 8 is not a human caspase, fine? Let's assume this is what happens in the extrinsic pathway. I'm going to stop in the extrinsic pathway. We'll go to intrinsic pathway. After completing intrinsic pathway, we'll learn execution phase. Like I said, it can start as extrinsic or start as intrinsic, but ultimately it will end in execution only, fine? Perfect. Now the intrinsic pathway. So intrinsic pathway has one more name, also called as mitochondrial mediated pathway. I didn't say the extrinsic pathways are the name. Extrinsic, cell membrane mediated pathway. Intrinsic, inside mitochondrial mediated pathway. That's all. It's very simple terms, right? So for my intrinsic pathway of cell death, I need to learn a few basic genes. Like I said, everything here is under genetic control. I have 3 groups of genes. We call them as, let's use classical terminologies as in Robbins. We call them as anti-apoptotic. We call them as pro-apoptotic. I'm sure you know what does it mean. Anti-apoptotic is going to obviously oppose the cell death. It's going to protect the cell's longevity. Pro-apoptotic is going to induce apoptosis. And we have something called as sensors of cell stress. Okay. These are three major divisions by which Robbins divides. There are two things which I want you to remember here. Sorry. All these genes, the pro-apoptotic, anti-apoptotic, are there in the mitochondrial membrane only because it's a mitochondrial pathway. There's no use of these genes or the proteins of these genes to be present in the cytoplasm. They are present in the mitochondrial area only, fine? Because all of them are mitochondrial induced. Second thing, if you see Robbins, these anti-apoptotic gene will be called as BH1 to 4. This will be called as BH1 to 3. This will be called as BH3 only, right? There have three different things here. This is called as only BH3. So do I need to learn this? My first answer is going to be no, you will not learn this. So what are these? If you remember your biochemistry, every protein is made of few amino acid domains, right? Like if I have an sulfur containing amino acid, I have some unique name for it. So these are all protein domains. BH is a protein domain. The anti-apoptotic proteins will have 4 of them. Pro-apoptotic will have 3 of them. Sensors of cell stress will have only 1 of them. Right? BH3 only will be there, right? So that's what it means. The thing, all of them are just protein molecules. That's all. If you can remember, otherwise ignore, leave it, fine. So I'll come to anti-apoptotic. But I want you to remember the genes or the proteins. That is very important for me, right? When I go to anti-apoptotic, I have BCL2, okay, MCL1, BCLXL. This was a mnemonic told to my senior, me by my senior. I'm going to just share it with you, right? Because I don't create mnemonics. I'm not as creative as you guys are, fine. So L, wherever L is there, right? It symbolizes a longer life. L for longer life. Longer life means they are anti-apoptotic, right? A simple way to remember, if you can remember like this. Otherwise, if you have any other way, do let me know. If your way is more attractive, I'll tell to everyone with your name, fine. They have longer life for L, so they are all anti-apoptotic, except one. The exception is what creates all the confusion. I'll try the except soon, fine. The pro-apoptotic, the major pro-apoptotic genes are BAX and BAC. I have one more pro-apoptotic guy, BCLXS. Maybe S for small. It shrinks or destroys the cell. Way to remember. But this also is BCL. One of the BCL protein which is pro-apoptotic is BCLXS. I'm just writing this. It's not important for me, but this might pull your legs down in an exam hall. Fine. So everything L is that. I'll tell you, Paliva. Just give me a second. Fine. Rest are backs and back. These are my major pro-apoptotic genes. I don't want this BCLXS, but yes, do remember that. Fine. Okay. I'll come to sensors of cell stress. The BH only domain, right? What do I mean by that is, so here I have three things, three important groups: BIM, BID, BAT, Puma, Naxa. Again, these are all just names. The best way to remember names for me is ask your friends, ask random queries. Maybe after this class or during the class, you go and eat in a mess. You ask what is BIM, BID, BAT, Puma, Naxa. The guy will think you are a nuts, but still you will remember them, right? Ultimately, the goal is to remember. More you repeat, more you'll remember because these are facts. There's no way to remember them logically, right? But BH means, like I said, let's say that I'm having the BCL2 protein. This is the BCL2 protein. Here I have this domain BH, BH, BH. I have 4 domains. BH1 to 4 means I'll have 4 BH domains. That means it's an anti-apoptotic. It's a protein thing. So this BH, everything are amino acid. If you remember amino acid, everything has an alphabet, right? Phenylalanine stands for F. Either I have alphabets. So this BH is a protein domain. If you have 4 domains, it's anti-apoptotic. If you have only 3 domains, like this, let's say, only 3 domains, pro-apoptotic, 1 to 3. If it's only third domain, sensors of cell stress, right? I hope it's clear, fine. Okay, I'll just erase this. Okay, that's what I mean by the domains, right? So now I know normal. I know all the ingredients required for me to design the program because of program cell death. This next is I want to learn what happens in normal cell. When you know normal, abnormality is a piece of cake, right? So we'll see normal cell means I'm saying a normal living cell. It's going to live smoothly. There's no problem at all, right? Let's say this is a mitochondria. Not a great person, not an artist. So please bear with me, right? That's a mitochondria. Let's assume it's a mitochondria, fine. Let's say in a normal living cell, a cell is going to live, which means the cell is not going to die. Which protein will be more, pro-apoptotic or anti-apoptotic? I want you to comment. A normal living cell will have more pro-apoptotic or more anti-apoptotic. It's living, not going to die. No apoptosis, so anti-apoptotic. Which is the major anti-apoptotic protein for me? The BCL2, right? So what happens is, I'll have BCL2 here. BCL2 will be present here, right? So the function of this BCL2 is simple. They will reduce exit of an important protein. Exit of one important protein, cytochrome C. Okay, they'll stop the exit of this protein, that's all. Which means I'll have cytochrome C inside. I'm just putting these red dots, these are cytochrome Cs, which is present inside the mitochondria, so they'll not come outside the mitochondria, right? Now again, a very simple question. If you remember the normal biochemistry, where have you read about cytochrome C? You're just fresh out of your first year MBBS. Cytochrome C, does it ring a bell? You must have read about complexes of electron transport chain, right? So in other words, my goal is very simple. Cytochrome C function is to produce ATP, which means they should be inside the mitochondria only. If they leak outside, no cytochrome C, ATP cannot be formed. The cell will automatically die. The funda is very simple. BCL2 is going to say that cytochrome C, your function is to produce ATP. You are one of the important person in the electron transport chain. Stay there. Don't come outside, right? Perfect. So that's what BCL2 does. It makes sure they live there for a longer time, right? Okay, now let's understand what happens to when there is a stress. So here my important stress is DNA mutation. There's a huge stress. Mutation is not always related to disease. Mutations happens to you every day. When you walk in the sun, UV rays cause mutation. My body takes care of it with the beauty of apoptosis. It kills everything, all the mutated cell, right? So this is the major or the most important pathway. The intrinsic pathway is most important compared to my extrinsic pathway, right? Let's see what will happen when there's a DNA mutation. DNA mutation is a stress, right? Right? It's a stress. Ashkanya, I am not sure about which complexes. I'm sure you will be right, right? So DNA mutation is a stress for me. Whenever there's a stress in my body, which group will increase? I'm going back. We have three groups. They are absolute names. Obviously, the sensors of cell stress will increase, right? Because there's a DNA mutation is a stress for me. This increases BIM bit bad pulmonoxa. Okay, this increases your BIM bit bad. I'm not writing everything. I just understood it will increase the sensors of cell stress. So when the sensors of cell stress are increased, they have two rules. Now I have to kill the cell. That's my goal, apoptosis, right? Which means, should I make sure BCL2 is still there or BCL2 should be destroyed? Because BCL2 is stopping the exit. So the first goal of this bimbidbat pulmonoxa is destroy BCL2. Because if BCL2 or any other anti-apoptotic genes are there or proteins are there, they're going to stay there forever. The cell will live forever, right? First, destroy BCL2. The second thing, it also does one more thing. It increases or activates your backs and back. Okay, it increases or activates backs and back. Backs and back becomes more. Backs and back is also in the same location of BCL2, mitochondrial membranes, right? It's also in the same mitochondrial membrane only. Let's say the same thing. The only thing is, it acts a bit differently, that's all. Let's use a green color. There's a backs and back. These are my protein channels. These are ion channels, simple ion channels, right? So this backs and back will just make them go outside. Will promote the exit. Okay. The BCL2 was reducing the exit of your cytochromes. Here, this is going to do the exactly opposite. Not just cytochrome. I have few more things. We'll learn both of them, right? The first important thing is they will promote exit of cytochrome C. So the cytochrome C will go outside of the mitochondria, which means ideally they're going to go to cytoplasm. That's all, right? Cytochrome C goes to my cytoplasm. It's simple. Now my cytochrome C is out in the cytoplasm. Can I say mitochondria will stop functioning? Will not produce ATP? It will not, right? It's dead. That's all. It's completely gone. It's dead. It cannot produce anything, right? So it's not just cytochrome C. Most of us will concentrate only on cytochrome C. I'm going to introduce one more new protein. I'm not telling anything which is not there in Robbins. It is there in Robbins, right? Yeah, two more proteins called as SMAC and Diablo. This might be a bit new. You must have ignored them because every emphasis goes in cytochrome C only. Cytochrome C goes to cytoplasm. Along with that, I have two guys called as SMAC and Diablo. We'll see what these things do. There are two groups of proteins. Both of them will have different functions, right? So let's take cytochrome C for example, because cytochrome C obviously is the most important guy for me, right? The cytochrome C binds to one more protein called as APAF. Again, it's an abbreviation. Don't worry, we are reading too many abbreviations, but all of them are as very easy abbreviation. APAF, apoptosis activating factor, right? It's very simple, right? It's apoptosis activating factor. It's apoptosis activating factor. So this cytochrome C binds to APAF and which forms a molecule or a protein complex called as apoptosome. You will read lots of terms ending with some, apoptosome, inflammasome, lysosome. Whenever I call it a some, it's not a single protein, it's a combination of proteins. That's what we call it a some, right? Okay, it's a combination of protein, we call it an apoptosome. So how is an apoptosome is? It'll look like this. I'll give you an exact picture of apoptosome, the molecular picture of apoptosome soon. It's a protein with multiple protein components. There are lots of them. All of them will unite, right? And the function of apoptosome is it's like a machinery. Well, let's say it's like a machine like this. One protein goes here, it cleaves them and sends them outside. That's a function of apoptosome. So procaspase goes to the apoptosome, cuts, becomes an active caspase. One more procaspase cuts, becomes an active caspase, right? Simple. Just to remember, what are the procaspase numbers in your extrinsic pathway? Can you comment? Same thing is being done here. The caspase will go outside. I have the procaspase. There was 8 and 10. Here it's procaspase 9. Becomes an active caspase 9. That's all. Okay, then active caspase 9 becomes. That's what the function of apoptosome is. So ultimately, the end product of intrinsic pathways, I have an active caspase here. That's all. We just read about one half, the cytochrome C. We'll look at what does SMAC and Diablo does. I have to one more guy, right? SMAC and Diablo. So what does SMAC and Diablo do is, fine. Okay, what does SMAC and Diablo do is, so SMAC and Diablo is very simple. For everything in my body, I have both like positive feedback and negative feedback, right? That's very, very important. Without a positive and negative feedback, I might not be able to lead a perfectly normal life. So SMAC and Diablo binds to the negative feedback. We already have, guys, see, APAF is apoptosis activating factor. So in the cytoplasm, we already have people which are IAPs. IAP stands for inhibitors of apoptosis. So the function of SMAC and Diablo is simple. I already have a protective mechanism for me to stop apoptosis. SMAC and Diablo binds to them and they will destroy them. SMAC and Diablo just destroys IAPs. So I hope it's clear. Two protein groups came outside. One is going to activate apoptosome, form the caspase needed for me. The other one is going to destroy the inhibition so that I'm having a free will to go and kill the cell. That's all, right? Now I'll go back to the top. I hope you must have left the gap. Our goal is to remember a few things. Right here, caspase 9. Okay, so we had caspase 8 and 10 extrinsic, caspase 9 intrinsic. So now we'll look at the execution phase. What happens in execution? Execution is very, very simple, right? So you know what happens? There's actually a molecular picture of an apoptosome. It's a protein structure. That's how it looks. Can you see a central gap here? Via this gap only, all the protein caspases goes inside and just cleaves and it comes outside, right? That's how a caspase looks. We know about the extrinsic, we know the intrinsic, we know the initiator phase. Next is the execution phase. It's simple. Whatever may be the caspase, 8 or 10 or caspase 9. But tell me, what do you mean by caspase? Can anyone tell what is a caspase? Caspase is a simple thing. Caspase is actually a protease. It's nothing but a protease, right? It's just a protease. The function of caspase is to cleave proteins, that's all. That's actually a very classical term. We'll learn it soon. So these caspases are going to activate more enzymes. This is going to activate two more enzymes, few more caspases group, right? 3 and 6, and also it activates endonuclease. Now I just want you to answer. This is very, very important. I want you to understand and answer. If you remember necrosis, in the irreversible cell injury, we had 3 enzymes getting activated, right? Here I'm having 2 enzymes. What is the one enzyme which is missing here? One enzyme is missing. What enzyme is that? phospholipase is missing, right? Perfect. So phospholipase is missing for me, right? That's why apoptosis doesn't have cell membrane damage. It has protein damage because caspase is a protease and it has endonuclease, nuclear damage. Apoptosis will not have cell membrane damage. If there is no cell membrane damage, can I say protein or the intracellular contents will not leak outside? Can I say inflammation will not be there? It will not be there, right? That's why it is not there, right? So phospholipase is absent here. That's why necrosis is different. It behaves differently. Apoptosis behaves differently, right? Just to add just one more information, we'll look at caspases soon and we'll look at endonuclease soon, what they will do. Caspases. Caspases are nothing but they are proteases which cleaves after the aspartic acid site. C for cysteine. These are proteases. They are cysteine containing proteases. It's just a protease. They are cysteine containing proteases. They will cleave after the aspartic acid. Wherever there's aspartate, okay, it will break them. I'll write just aspartate. Cysteine containing aspartate. Caspases is for the proteins, right? That's what caspase literally means, fine? Okay. So now we know there are two things. Now our protein is very simple. You guys know everything. I'm just going to give you the flow. You're going to answer it, right? The fastest finger first, ready to answer. I have two guys. One is caspase. Other is endonuclease. We'll look at that soon, fine? I'm having a beautiful cell like this with an amazing good amount of my protein. Okay, the cellular protein. I have a very good nucleus also here, fine? Okay, we have a very good nucleus also here, fine? So this is a live cell. Now, caspase is going to act on this cell. First thing, will the protein here become light or dark? Caspase is the protease which will destroy protein, so the protein will become light or dark. Undoubtedly dark. We know that, right? We know it's the same protein, same concept what you read in necrosis. Second thing, I'm having this big protein. I'm going to destroy the protein. Whenever I destroy a protein, it becomes a precipitate. The precipitate will be smaller than the original protein or bigger than the original protein. It's a precipitated protein. It will be condensed in small or bigger. It will be smaller, right? Perfect. So can I say when a caspase attacks a living cell, it will make the cell smaller because it's going to destroy every protein, which will shrink automatically, right? It will automatically shrink. So what happens here is I'll have a nucleus again. I'm drawing nucleus. I have a very, very dark protein, right? I don't have a dark pink color. I'm just drawing it dark, right? Two things here for me. I'm going to use the same term what we used in necrosis. I will have same intense eosinophilia. So this is not for necrosis alone. It's for cell death. Second important thing is cells shrink. They shrink. What happened in necrosis? That's a difference. In necrosis, we had cell swelling. Here, cells shrink, right? That's one thing, right? Now look at the second cell or second enzyme, endonuclease. They have a difference again here. In necrosis, if you remember, we read about nucleus, not an endonuclease. You might be wondering what is the difference. There is a difference. I'll tell you the difference and you know the difference. The only problem with you guys don't know that you know many things. In your biochemistry, have you read about something called as restriction endonucleases? You have. Every endonuclease has a template, be it restriction endonuclease or not. Every endonuclease or restriction endonucleases cuts only on what sites? Palindromic sites, right? You must have heard them for sure. You will definitely remember them, right? Let's say I'm having a DNA like this. Okay, I'm having a DNA like this. Fine. Okay, let's assume I'm just writing here. This is a palindromic site. I'm writing P for palindromic site. You must have definitely heard about palindromic sites, right? So can I say when the endonuclease acts on this palindromic sites, it will just destroy them into pieces? If these are the palindromic sites in this DNA, it will destroy them here. Am I also right in saying that this endonuclease cannot act further on this DNA because the palindromic sites are gone? Yes. So the palindromic sites are gone and endonuclease cannot act. So now tell me, will there be karyolysis in apoptosis? In necrosis, we had pycnosis, karyolexis, Karyolysis. Will there be karyolysis in apoptosis? No, there'll be no karyolysis. Which means, can I say the cell is dead, but still I'll have blue color? Yes or no? Obviously, you'll have blue color, right? Because there's no lysis, there's just fragmentation. Rexis happens, destruction happens, but no lysis, right? Perfect. Because this, I want you to learn, I want to understand and learn. So, which means here nucleus will still be present. Now, my only second question is this nucleus here is functional nucleus or non functional nucleus? It's a cut DNA, functional, non functional. Non functional. Euchromatin, heterochromatin. Heterochromatin, light, dark, dark. So I use a term. Terms are very important, right? We have to derive why I use the term. The term is simple. I call them chromatin condensation. Now these are the only changes which happens in apoptosis, right? I'll just go up slightly. I have protein and I have nucleus. Now tell me, of these two, which is more suggestive of cell death? When a protein is dead, can I say a cell is dead? Or when a nucleus is dead, can I say cell is dead? Obviously nucleus, right? Chromatin condensation makes much sense for me to say call it a cell death. So an MCQ comes there, right? This is the hallmark feature of apoptosis. It doesn't matter, don't memorize. I have two changes. One has to be hallmark. But necrosis, add phospholipase, membrane rupture. Which is hallmark? Membrane rupture or nucleus rupture? Membrane, because membrane gone, it will never come back, right? So you have to just differ. I have two cell death. I'm going to compare simultaneously. I know one already. I'm going to learn one. Other one I'm going to compare it, right? So these are changes that happens, fine. So the end of it, what happens is I had a beautiful cell like this with, let's say, a super pink color. Maybe I'll draw a bigger nucleus because I have to show it's a condensed nucleus, right? Then after apoptosis, what happens is it becomes smaller, a very dark nucleus, and maybe a very dark cytoplasmic membrane where it disappears. Okay, and a very dark cytoplasm, fine. A dark nucleus and a dark cytoplasm. Okay. Okay, just let's assume like this, fine. Got it. Now here, this I'm going to name them as apoptotic body. So can I say apoptotic body everywhere from head to foot will be the same, be it CNS or be it toe? Yes, learn that. Apoptotic body will be smaller than the original cell, darker than the original cell, and condensed chromatin. That's all. That's how apoptotic body looks. It looks smaller, it looks darker, and it will have condensed chromatin. Okay? The chromatin is not always necessary. It will have that, right? So tell me next thing. What do you think is the ideal thing? This apoptotic body should be there forever or this should be removed? It should be removed, right? It has to be removed. So I have a cell which eats every guy. Who's that? Macrophage. The macrophage is going to eat this. I always believe that human beings are all macrophages. We are all macrophages. We know to eat. We know only to eat. We'll eat anything which is tasty. We'll bite and eat whatever moves. Macrophage is same. Macrophage eats everything which has been tasty, right? So what happens is for a macrophage, it's very difficult for it to eat the entire cell. You have a big laddu. It's very difficult to swallow. Some of us do, but it's very difficult, right? So I break them into pieces. So what happens here is next thing here, this cell will have tiny blebs. So let's say I had a cell which is what was blebbed, which is bleb. So I have tiny parts. That's why I said which can have chromatin, might not have chromatin. But whatever bleb is formed, they will always have a cell membrane. That's the difference between necrosis. Necrosis also had bleb, but it ruptured. Here they just divide into tiny things, right? So it happens, and this will be removed by macrophages. Macrophage obviously removes them. There are two learning things for me here. So you just said this. You guys said that apoptosis everywhere in my body looks the same. Yes. So every apoptotic body will look the same. But unfortunately, when you go to your microbiology, hepatitis, or in medicine or in liver pathology, we term something as councilman bodies. It's nothing but apoptotic hepatocyte. We have something called as civet bodies. It's an example of apoptotic skin cell, keratinocyte. It's an apoptotic cell. Councilman found it, gave the name. He must have called it apoptotic body. Very, very simple for me, right? There are few terms of apoptotic body called as councilman bodies. Councilman body is seen in hepatitis. It's very simple. Hepatitis, virus induced. Will it cause apoptosis? It will cause apoptosis. Councilman body, that's all. I have a body, one more name called as civet bodies. Civet bodies is seen in a disease called as lichen planus. You need not worry too much. You are very young, so these lichen planus, all these things will look very exotic things. It's very simple. It's a very simple disease. Go to final year, you can diagnose lichen planus, you can treat lichen planus, fine. So these are all apoptotic bodies. So over the period of years, when you go to systemic pathology, what I will do is I will tell only apoptotic body. I don't care about councilman diagnosed and discovered it or sweat diagnosed and discovered it. My goal is to diagnose. Your goal is to diagnose, not to please councilman or sweat. We'll learn apoptotic body. Anywhere it is virus, it will cause apoptosis. Anywhere there is a mutation, it will cause apoptosis. Anywhere there is a protein accumulation, it will cause apoptosis. And all the diseases which falls under these categories, microscopy will have apoptosis. I already have a finding throughout life. You relate everything. That's enough for me, right? Perfect. That's the first extrapolation. Second thing I want you guys to answer. In apoptosis, inflammation is present, absent. Answer the question. In apoptosis, inflammation is present or absent? In apoptosis, inflammation is absent, right? Who is this guy? Macrophage. Inflammatory cells or not? They are inflammatory cells, right? So what happens is, though macrophage comes in apoptosis to remove apoptotic body, but we always learn that in apoptosis, inflammation is absent. So why do I call that? Macrophage is present. We know macrophage is the one which removes apoptotic body. We'll see how it removes, right? See, I want you guys to ask questions, that's all. Everyone knows here it's absent, but everyone knows here macrophage will come. Everyone knows macrophage is an inflammatory cell, but still I call it absent. There's a discrepancy. Go and question. And in question, you will know more answers, that's all. Fine. So what happens here is, for every macrophage to act, everyone here knows that it should be opsonized. You must have read in your early stages of immunology and microbiology, right? I need to cover them with something tasty, only then a macrophage will eat. One of the best opsonizing protein is complements, right? The complement proteins covers the apoptotic body, the fragments or the original body, so that macrophage can engulf it. Now, two more protein. They have something called as phosphatidylserine. Okay? Yeah, phosphatidylserine. This is very important. I want you to remember this. We'll learn this again when we come to hematology. It's superbly linked, right? The other guy called as thrombospondin. So what happens is, these are called as eat me signals, right? Phosphatidylserine and thrombospondin, Robbins call them as eat me signals. So these eat me signals are present only in an apoptotic cell, especially the phosphatidylserine and thrombospondin. Macrophage identifies them. Macrophage engulfs them, eats them. The beauty of macrophage is it eats without releasing free radicals. If there is no free radical release, can I say there will be no pain? There will be no tissue damage? Because free radicals destroy everything, right? It destroys everything. So here, in the presence of these two are very important for me. In the presence of phosphatidylserine and thrombospondin, the macrophage eats without the release of free radicals. That is very unique way of eating. Because till now, for last many centuries, we learned that macrophage eats by releasing free radicals. Here they eat without releasing free radicals. That's why I had a new term. We coined this entire thing. We call them ferroptosis. We call them ferroptosis. Ferroptosis is nothing but phagocytosis of apoptotic body. Right? Sorry, it's efferocytosis. Sorry, ignore this. What is efferocytosis? The ferroptosis was there in mind, right? It's efferocytosis. Fine. Sorry. It's called as efferocytosis. Fine. It's eating same phagocytosis, but it's eating without releasing free radicals, so no inflammation. We are still researching how it does this. I'll leave it with a question mark here. Always you have to keep asking why, how, what. You keep asking, you learn for sure. Let's say that after long research, I understood that this is how efferocytosis happens. I know that macrophage can eat things without releasing free radicals. If I'm able to implement efferocytosis to a TB bacilli, can I eradicate tuberculosis? Can I eradicate any chronic inflammation? I can. So I just want to learn this. I hope in future, maybe if you're live or not that time, I'm not sure. Maybe in future, I will be able to tap it and use it for pathogenic organisms. So you eat the organism, but please don't release free radicals and those don't cause damage to my body. That's a very unique way of phagocytosis called as efferocytosis, right? Clear? So that's how apoptotic body is being cleared. So we know how it's done. Our goal is not to learn how it is done. My goal, your goal now and in the future is only one: diagnose patients, make sure the patients are treated properly. Which means I have to predict apoptosis. What test do I have? How can I say, okay, this cell is apoptotic, right? How can I say this cell is apoptotic? Very simple terms. The first one is HNE, normal biopsy. You know that apoptotic body will be smaller, darker nuclei, and darker cytoplasm. That's a first image based, fine. Second, cytochrome C biochemical assay. Tell me, when will you call a cell is apoptotic? When cytochrome C is in cytoplasm or in mitochondria? When will you call it apoptotic? Cytoplasm or mitochondria? Cytochrome C in? Perfect. Cytoplasm, right? When I have cytochrome C in cytoplasm, which means the cell is dead, it has to be in the mitochondria. If it goes to cytoplasm, obviously gone, right? Third, we just now read about two proteins which were expressed in an apoptotic body: phosphatidylserine and thrombospondin. I can either assay them or I have a very good assay. We have a protein marker. There's a marker called as annexin. Okay? I'm not naming the annexin, I'm just calling it annexin because I will use this annexin again when I said when I come to hematology. This annexin binds to phosphatidylserine. I'm writing PS for phosphatidylserine, right? So let's say I'm having a cell where annexin is positive. That cell is living cell or dead cell? If annexin positive means the phosphatidylserine is expressed, which means it's an apoptotic body. When annexin is positive, I can call it happily it's an apoptotic body. It's a dead cell, that's all. Because annexin binds to phosphatidylserine that is not expressed outside in a normal cell. Only when it becomes an apoptotic body, it's expressed, right? Perfect. Next, we have a assay called as tunnel assay. I am not going to talk about tunnel assay. Maybe when you come to your entrance preparing phase, if you're targeting INACD, that time we'll learn. Because tunnel is a bit too much for an undergraduate level. It was asked once in the AIMS exam. Just remember tunnel. Tunnel assay is an assay for apoptosis. That's more than enough, right? Perfect. So tunnel assay also helps me to assay apoptosis. Next one, I'll definitely talk about it and we'll understand also. We have something called as DNA electrophoresis. Have you read electrophoresis in your biochemistry? Yes, no. Somewhere, right? I'm sure you must have read about electrophoresis, right? You must have read about electrophoresis for sure. So electrophoresis, can I say that every protein or the DNA moves based on the molecular weight and charge? I put a protein, have cathode anode, it moves based on the charge and the molecular weight, right? That's all. So now what we're going to do is, I'm going to do electrophoresis not for a protein, for a DNA, nucleic acid, that's all, right? So what we do is, let's say I'm having an every electrophoresis is agarose gel. It happens on agarose gel, right? It's an agarose gel electrophoresis. So I can call it a normal DNA electrophoresis or a DNA agarose gel electrophoresis. Both means one and the same, right? I'm putting the nucleus here. It's not moving at all. So can I say when it's not moving, can I say the entire nucleus is in, as one mass? It's not even moving. If it moves, there are particles. I mean, is this statement right? If it moves, there are particles. If it's not moving, it's a single mass, right? It's not moving at all. Let's put that as one. You are going to interpret that very soon. The second cell which I put, right? The second cell which I put, it moved like this. It just moved like this. Tiny, tiny, tiny bits. Can I call its form of multiple bits of DNA? Yes, it's form multiple bits of DNA. The third is even more better. The third thing, when I did an electrophoresis, what happened was it was like this. It is just like a smear. It is not anything, it's just like a smear. Which means, can I say the third one here, it's not having bits of DNA, it's having lysed DNA, right? Perfect. Here is an intact nucleus. What is an intact nucleus? I'll repeat it, Sonu. I'll show you real image and I'll repeat it for sure, right? And an intact nucleus, which means it is completely normal cell. Because if it's intact, not moving at all, only one nucleus, perfect round intact nucleus, it's not broken, it's not dead. And I have something like this, multiple bits and pieces. Okay, just give me a second. I think WhatsApp is on. Fine. Is it fine? I hope the audio is good. If the audio is good, just give me a thumbs up. Yes, say yes or no. Fine. Okay, is the audio better? Not better? Because for me it looks better. I'll repeat it again. The second thing here, I had bits and pieces of broken DNA, right? When I had bits and pieces of broken DNA, and bits and pieces of broken DNA, it means it's broken DNA material, right? When I had broken DNA particles, you are going to tell me what it means. Here, it's cut DNA or lysed DNA. It's broken DNA, it's a cut DNA. If it's a cut DNA, this action is based on endonuclease, which cuts at palindromic sequence, or a nuclease which lyses everything. It's based on endonuclease. If it's based on endonuclease, the second picture is apoptosis or necrosis. Perfect, it is apoptosis. We gave a fancy term for this. We call this an step ladder pattern. Okay? We call this a step ladder pattern, and step ladder pattern of electrophoresis is diagnostic of apoptosis. If you know this, the third one is very simple. I'm having a smudged DNA. It's there, it's lysed, that's why it's completely gone. Pycnosis, karyolysis, karyolysis. This is called as a smearing pattern. It's totally a lysed DNA. Whenever I have a karyolysis, I give a term, it looking like a smear, so I call them a smearing pattern of DNA electrophoresis, and smearing pattern is absolutely seen in necrosis, right? Fine. I hope it's clear. Sonu, it's clear. Whenever you had audio problem, I hope it's clear now. An intact thing is a normal cell. Broken bits of DNA, I call it an apoptotic cell, step ladder pattern, and lysed DNA, I call it a smearing cell. It's a necrotic thing. Fine. Okay. This came in an AIMS exam. I will show you the real image. I'll come back to this. This is the image which came in AIMS exam. It's a very simple image, right? Now you guys are going to tell this. What is this? This A. I'm just going to name them as A, B, and C. A is completely normal. I will write as normal. I won't put it as N. Right? It's completely normal. The second one, the B. Can I say there are multiple tiny bits and pieces? Yes. The ladder, right? This is your I can write. I'll use this. That's your step ladder pattern seen in apoptosis. The third one, looking like a smear, right? It's simple. Once you understand, it's very, very simple. It's not difficult at all. It's necrosis, right? So you know how to interpret a DNA protein electrophoresis or a DNA agrosgel electrophoresis in necrosis, in apoptosis, and a normal situation, right? Perfect. Got it? Great. Fine. So now this is done. Now let's go back to the HNE. The normal image. That's how we have to interpret an apoptotic body, right? Let's say this is a normal cell. This cell is a normal cell. I'm going to compare that cell with this guy. Can I say this one, the lower one, is definitely smaller? The cytoplasm, can I say it's dark pink in color? This guy, it's definitely dark pink in color, right? It's definitely dark pink. The nucleus, compared to this nucleus, look at this nucleus. Can I say this darker nucleus? It is. So this person is out. an apoptotic body looks like. If it's a liver, I can call it a Councilman body. There's a normal cell, right? You compare a normal cell with abnormal, it's very, very simple. Smaller cell, darker cytoplasm, darker condensed nucleus. That's how an apoptotic body looks like, fine? Great, perfect. So we know how to diagnose or identify apoptosis. We know entire thing about apoptosis. It's done. That's all. It's a very simple way of leading. It's linked. Everything is linked one by one. We know why it's called as apoptosis, why it's programmed. You know what are the types of things, extrinsic, intrinsic, FAS ligand, and all the BIM, BID, BAT, P1 acts are pro-apoptotic factors. We know how caspase acts. We know the execution phase. We know efferocytosis, how it's been eaten. Everything we know about it, right? Perfect. Just one. The difference. This is where you have in your exam. See, please take it from me. Whenever you have a table in any book, whatever book it is, not just Robbins, any book in your life, when you have a table, don't read the table. You can never excel a table. You have to read the entire text, then recreate the table. Recreating the table is very, very simple. Once you know everything, recreating the table is very simple. You have a table in Robbins of necrosis and apoptosis. We are going to recreate it. You're going to recreate it, right? I'll just give you the features. You tell me what happens. Then you will not find it difficult at all to read the table, right? We'll put necrosis. We'll put apoptosis. We'll read exactly what is there in Robbins. But now you are the author. You're going to write. I'm just going to tell you features. Tell me what happens to the cell's size. Fastest finger first. In necrosis, cell size enlarges or shrinks. It will swell. In apoptosis, cell shrinks. That first point is done. Nucleus. Not just cell, nucleus also, you know. What are the nuclear changes in necrosis? I'm not writing everything. I'm just writing pycnosis, karyorrhexis, and karyolysis. Yes, that's what happens in necrosis. In apoptosis, fragmentation. Simple. If you have Robbins by the side, open Robbins. I'm just going to recreate the entire table in Robbins. Fine. Third, plasma membrane. I'm using the same terms as what Robbins says so that you will feel that Robbins is not difficult. Plasma membrane in necrosis, normal, destroyed. Destroyed. Plasma membrane in apoptosis, it will be intact. It will definitely be intact, right? It will be intact. What Robbins says is the orientation of lipid structure, everything will be intact. Structure will be a little bit altered, but intact. That's enough for me. You don't want to learn Robbins line by line. It's intact cell membrane. That's more than enough for me, right? Perfect. The next thing, what will be then Robbins is cellular contents. Cellular contents in necrosis. Will it leak out of the cell or it will not leak out of the cell? It will be leaked. It will be digested and leak out of the cell, right? It leaks out of the cell. That's what we use it for diagnosis. Troponin I, troponin T in your myocardial infarction, right? That's what we used. In apoptosis, they don't leak outside because they're intact. They'll be inside the apoptotic body. The cellular contents will be maximum, I can say, it'll be inside apoptotic bodies. Right. Next, inflammation. This is where we started with, right? This everyone knows. Inflammation is present in necrosis. It's absent in apoptosis. That's all. Next is the physiological pathological. Again, I will use very normal information. You're going to tell me inflammation is present. Wherever inflammation is present, definitely there'll be pain. So can I say necrosis is almost always pathological because I cannot have a physiological cell death which will cause pain. I can never call it physiological, right? It's almost always pathological. I'm not saying 100%, but mostly, right? Mostly pathological. But apoptosis is both physiological and pathological, right? Simple. You recreate a table. Don't read a table. The problem in trying to memorize a table is you will forget. But when you recreate, you know every difference. If you want, you can write more thing. Under genetic control, not under genetic control. Not program. You can write multiple things, right? Stepladder pattern, smearing pattern. You can write whatever you want. You have n number of possibilities, right? So what you do is you learn the text, then go to the tables. Take it from me. Every flowchart, every table in any standard textbook is to revise, not to read. If you use them for revision, it will be amazing. If you use them for reading, That's where we end up in problem. What we do is we read small textbooks, notes, copies. That's what we learn. Where only this table will be given. You will read the table. You will be like, wow, very easy. After 1 week, you'll forget. Then you'll not blame the book. You will blame yourself. Please don't do that. You're amazing young kids. I never ever want you to say that you have a poor memory. I never ever want to say that you're not a good student. You are an amazing student. You are in MBBS. You are an amazing student. And you will be an amazing doctor also, right? Recreate tables that will be very easy for us to remember on long term. Read the way we have to read, fine? That's done with apoptosis. Yeah. The next part of today's discussion is intracellular accumulation, right? In the starting, I said it's intracellular, it's not inter, it's intracellular accumulation, fine? First, why do I need to learn, right? Intracellular accumulation, right? So let's say there is necrosis and apoptosis, which are the major forms of cell death. A pathologist is like a police. I will never come when the cell death. I will always come when the cell death is over. Because am I right in saying that a patient will not come exactly to the doctor when the virus goes and hits the liver cell? No. After jaundice, after fever, take paracetamol for 5-6 days, not settling, then only they'll come to the doctor, right? The pathologist, as a pathologist, what I look in microscopy is not exactly death. I look at evidences of cell death, like a police. Police goes to the crime scene after the crime. So look at the wall. There's blood splashed in the wall. Okay, someone has killed and splashed. There's a dagger. Okay, knife. There's someone has killed them, right? So these are all evidences of cell death. All these are evidences of cell injury or cell death. So my role is I'm going to look at this evidence and I'm going to use it for diagnosis. My role is simple. I'm going to use it for diagnosis. I'm going to use this evidence for diagnosis. Robbins divides them into fat, protein, hyaline, your pigments, and calcium. The same thing only, but I have a slightly different approach because my goal is only diagnose, right? I'll use the same thing only, but I'm going to use it based on colors because colors are always exciting for us, right? I'll have something clear. What's clear in microscopy? I want everyone to comment here. You know, we have a thumb rule. Blue is nucleus, pink is everything apart from nucleus, clear is only one person. Who's that? Fat. If it's clear in microscopy, my first guy is okay, fat accumulation. Next is pink color. In pink color, I'm going to use two guys. Protein. Every protein accumulation will be pink in color. Also a little bit of glycogen. Glycogen will be pale pink to clear based on the accumulation, right? So anything pink in color, if it's accumulating, I'm going to think of these two guys. Fine, perfect. The third one is blue. Blue is your calcium. And obviously, apart from that, I have pigments. Pigments is not going to be pink or blue. It will be brown in color or black in color. Right? So my thing is to divide it based on colors. If you divide it based on colors, it's very easy for me to recollect. That's all. Right? It's either black or brown. Okay, important. So that's how we divide them. It's clear, pink, blue, and pigments. Fine. We'll learn the same way whatever Robbins talks, but a slightly different approach and classification so that you can use it for your next exam when you come to diagnose slides in IPQs. Fine. Let's come to fat accumulation. I have given you a little bit amount of base. You will tell me easily what is about fat accumulation, what I'm going to see them, right? So fatty change or fat accumulation both means one and the same. When I talk about fat accumulation, what is the first organ which comes to your mind? For everyone, there's only one organ which comes to the mind. What is that? When I say fat, steatosis, liver, right? That's the first person which will come to everyone's mind invariably, right? Then fat accumulation, I'm going to divide into two things. One is accumulation of triglycerides. That's also a fat, right? The other is accumulation of cholesterol and its esters. That is also fat, right? Cholesterol is also fat and its esters. The chemical modification, that's also fat, right? Triglyceride accumulation is what we generally when we use the term steatosis. Stia is fat, steatoria is fat, right? Steatosis is fat. It's seen in your fatty liver. Like I said, my only focus is fatty liver. Cholesterol and esters, we'll look at them very soon, right? The fatty liver, we'll read more things about fatty liver when we come to your hepatic pathology, but still I want to give a basic understanding of why and how fatty liver happens here itself, right? Look at fatty liver. Our goal is simple: etiology, microscopy, pathogenesis, diagnosis. That's all, right? It's very, very simple. We'll just look at the fatty liver now. Then we'll go to the cholesterol and the esters soon. You're going to tell me a few things. Something is accumulating in a cell or in an organ. Fat is accumulating in an organ, right? If fat is accumulating in an organ, can I say there are only two possibilities? The organ is not able to remove the fat normally, or more and more and more fat is being consumed that goes to the liver. That's all. Those are the two main problems in fat accumulation or anything accumulating, right? What is the first etiology which comes to your mind for fatty liver? Alcohol, right? Obviously, alcohol. Alcohol is definitely one of the important etiology of fatty liver. What happens in alcohol is alcohol alters your NAD NADH ratio because the alcohol dehydrogenase and your aldehyde dehydrogenase, the NAD NADH ratio will alter. Because of this, this increases fat production. Because if you remember the fat production in your biochemistry, it's driven by NAD and NADH ratio, right? Alcohol alters them. Because of that, there's more fat production which gets deposited in the liver. That's the reason one. Second, we read about PEM, protein energy malnutrition. We read that protein energy malnutrition, everywhere there'll be thin limbs, there'll be muscle atrophy. Can I say, wherever you touch your body, you'll have fat there. All this fat also will be atrophied in protein energy malnutrition, which means all the fatty acids from periphery goes to the liver, overloading liver, right? PEM is the most common cause of fatty liver in children. As of now, it's the most common cause of fatty liver in children, which converts peripheral fat into the liver. So when peripheral fat goes into the liver, it obviously causes more accumulation, more problem. That's the second, right? Perfect. The third one, which is more important for me, is NAFLD. We'll read about NAFLD more when we come to liver pathology, like I already said. It's non-alcoholic fatty liver disease. It's NAFLD, right? It's just non-alcoholic fatty liver disease. Now, can anyone say what is the most common cause of fatty liver? Just out of the mind, tell me what is the most common cause of fatty liver. I'll give you a different approach. See, my only goal is to just to make you think. If I am able to make you think even at least once in your life outside the book, my goal as a teacher is sorted. I just want you to think, that's all. Non-alcoholic is common or alcoholic is common? By default, mind comes saying that alcohol is more common, right? No. Non-alcoholic fatty liver disease is the most common cause of fatty liver in adults. My books might not say this. But this is the most common cause, right? The reason is oily food. I'll tell you why this is important for me. Now, non-alcoholic fatty liver disease is due to junk food. It's a metabolic problem, right? It's a metabolic problem. You eat more, it happens, right? You have your college, take a college, 100 or 150 per year. Let's take 700 people in the entire college. Not everyone is alcoholic. But can I say, invariably, every 700 students across the 5 years in your college will eat fatty foods? Definitely will eat fatty foods. Burgers, pizzas, street foods, trans fat are the reason for non-alcoholic. So this is undoubtedly the most common cause. My goal and your goal now and in the future is not to learn about the most common cause. It's to make sure what impact will it have cause in future. We have to think that way. That's where epidemiology comes. Your PSM has a major role in medicine. You don't like PSM, right? We hate PSM. Your PSM post some they must have thought about your community medicine, right? We don't like that much. I'll tell you what's the impact. Alcohol has an age restriction in my country. Age restriction around 25 years. but you get it before that also, it's fine. Let's say that 18 years the person starts drinking, 10-15 years will result in fatty liver. Okay, 10 years, 35, 10 more years result in steatosis, 5 more years result in cirrhosis. So if alcohol causes liver damage, cirrhosis comes somewhere around 45-50 years. It will cause hepatocellular carcinoma in 60 years approximately. It's a rough timeline. But this non-alcoholic fatty liver, junk foods are eaten by 5-6 year old kids, right? Burgers, pizzas, if you have a nephew or niece in your home, they will eat it. So from 5 years onwards, I'm eating burgers, pizzas, and junk foods. 10 years, it will cause fatty liver. At 16 or 17, the kid will have fatty liver. Continues eating, not taking care of the health. At 25-30, the kid will have cirrhosis. If it continues again in a worst possible way, at 40, there will be cancer. So what I'm doing is, I have a disease which is supposed to happen at 60 years old, but I'm changing it, making it to come 20 years early. I'm not saying that every fatty liver will result in cancer, but there's a risk for sure. If you don't take care of epidemiology, your kids will learn medicine saying that there's a bimodal age distribution of hepatocellular carcinoma. I don't want to read that. I want to stop the bimodal. You guys will stop the bimodal. Learn what is supposed to be learned. So if you have kids at home, restrict them. So this should go from my medical community to my government. Government will say stop fatty food, also restrict age. Once a law comes like that, we are in a perfect economy. We are in a perfect place. We are in a perfect country, right? So medical science should go into political science. Political science should give the plans. That's what PSM is there for. It's a link. And I hope we'll understand PSM, we'll appreciate PSM the way it should be done, right? So these are major causes for me for fatty liver, right? Now let's look at the gross and microscopy of fatty liver we'll take, right? Gross appearance of fatty liver, it will be enlarged for sure. Like someone said, I will definitely have hepatomegaly. That will be there by default. Hepatomegaly will be there. That's one. Not just enlarged, fat is always greasy, right? It'll always be greasy. Oil, you must have touched ghee. It's greasy. Okay. What do you think is the color of fat? In naked eye, what is the color of fat? Everyone here must have seen fat for sure. What's the color of fat? You don't know the color of fat? Everyone knows. Perfect. It's yellow in color, right? If you're a vegetarian or non-vegetarian, both of them know. Ghee color is yellow. Fat. If you're non-vegetarian, mutton biryani, the leg piece, yellow, fat. That's the tastiest part, right? Fat. Everywhere you learn, medicine is there. It'll be yellowish. What's the color of fat in microscope? Microscopic color of fat is clear, right? But grossly, naked eye, I'm having a color. Microscopy, it's clear. There's a mismatch. So the question is why it is clear, right? So what happens in microscopy is, if you be to a pathology department, you take a biopsy, you will be required to process the biopsy for 16 to 18 hours before I get the slide, right? So what happens is, whenever I get any biopsy in my body, we will process it. This processing is rich in alcohol. When I use alcohol to process, right, this kind of what it does is, it will clears the fat. It will clear the fat from the microscopy. Okay? It clears, or let's say it dissolves fat. That will be better terminology. It will dissolve fat. When it dissolves fat, what I'm actually seeing in microscope, fat or an empty space. Perfect. I'm seeing an empty space. I'm seeing an empty space in the microscope. That's why fat is clear. It's not the color of fat. It's an empty space where fat was present, which this alcohol dissolved it. Understood? Perfect. I'll give you one more question. It's always question and answering, right? It's clear in microscope. When we read about Barrett's esophagus, we learned one more thing which is clear. Mucus, right? So as a pathologist, when I look into the microscope, can I say it's clear fat or clear due to mucin? Can I say that? I cannot say that. If you cannot identify something on a light microscopy, what is the next step? What do you do and what you have to do? Perfect. You have to have a special stain. Since it's clear, there are many things which are clear. I need a special stain. You need a requirement and then you answer as per the requirement. Perfect. So the special stain here, this might come in your viva, and the next question which I'm going to ask you also will come in your viva. We have special stain colors. Sudan black. The stains are beautiful, right? It's black because it stains the fat black in color. And I have one more stain called as oil red. Okay, this will come in exam for sure. In your viva, they'll ask you if you have answered this, right? See, more and more you answer in your viva, the examiner's ego gets hurt. They'll ask more and more questions. You answer more, hurt them more, right? So when you answer this, the next question is very simple. So the PAS was for mucin, right? Not for fat. This is stains for fat. The next question is, if I do this Sudan black and oil rideau on a normal slide, will it highlight fat or not? Will it be positive or negative? It will be negative because what I'm seeing in microscopy, empty space of fat. It's an empty space, right? So it will not highlight. So in other words, in order to do Sudan black and oil rideau, what do I need is, I need a special type of processing called as frozen section. Okay, this might be the question asked and is there in your Robbins as well. I need something called as frozen section. I'll go up, I'll redo the process again completely. When a biopsy comes, I process the tissue. That will dissolve the fat. That makes them empty. So when I do an oil rideau Sudan black, it's an empty space. It will not be highlighted because there's nothing there. So for me to see fat under microscope, I need something called as frozen section. Frozen section is done within like 20 minutes. It will take only 20 minutes to do it. We'll read about frozen section sometimes more in detail. Here, this will not dissolve fat. This came once in an exam in your INICET. Okay, it will not dissolve fat. If it doesn't dissolve fat, it's good or bad? It's good. I can see Sudan black and oil rideau, right? The question which came in your INICET was, what is the fixative for your Sudan black and oil rideau? The answer is frozen section. You freeze them. You freeze them, fat will be fat. The best example of freezing will not alter fat is ghee. When it's frozen, it becomes thick. It doesn't disappear, right? Just thick, it'll be there. That's all. Fine. I hope you understood this. If you don't understand, just ask me if you have any queries now or later. I'll try to reply. Fine. So frozen section is the only way by which this can be used to demonstrate fat. Fine. Perfect. So let's look at microscopy. This is a liver biopsy. It's not difficult to identify, right? It's fat, fat, fat. All over what I have is fat here. All of them are fat here, right? It's clear vacuole. If I do, again to reiterate, if I do Sudan black or oil rideau here, it will be negative. But if I do the same thing on a frozen section, it will be positive. Fine. Is that clear? If it's clear, say yes. Okay, got it. Fine. Now let's go back to the other part. I'm going up because what we read was, we said one half is triglycerides. The other is cholesterol and cholesterol esters. I'm not going to talk many things about it. Just two examples, or maybe Robbins gives 3 examples. We'll read all 3 examples. Can I say, you must have definitely read about the disease. I will have cholesterol and cholesterol esters in a blood vessel in atherosclerosis. Yes, you will have, right? In atherosclerosis, you'll have cholesterol esters, cholesterol. That's an example for cholesterol esters, right? Atherosclerosis. We'll read all of them when we come to systemic pathology. It's accumulation of the cholesterol in the blood vessel. Second, I'm sure you must have heard about this term also in biochemistry in familial hypercholesterolemia. Have you heard of a term called as xanthoma? Xanthomas, xanthelismas? You must have. That's all accumulation. You must have read about tendon xanthomas, right? Here, I'm having fat accumulation in skin, subcutaneous tissue, and tendons. In familial hypercholesterolemia, you'll have that, right? That's also an example of cholesterol ester. The third guy, I'll just write here, mention it here, but we'll look in the image. Third guy, which happens in gallbladder. So in gallbladder also, I can have cholesterol accumulation. We have a unique type of disease called as cholesterosis. We'll read about them very soon, right? We have atherosclerosis, xanthoma, and gallbladder. When you have cholesterol accumulation and triglyceride accumulation is seen in fatty liver. Fine, clear? Perfect. Now look at the gallbladder. What's the normal color of fat? Yellow, right? Gallbladder is a very vascular organ. So let's say that the color of a fresh gallbladder is red in color. The mucosa is red in color. In that red color gallbladder, I'm having yellow dots. How would it look? Do you know any fruit which is red in color with multiple yellow dots all over? Any fruit which comes to your mind? Imagine, you know the answer for sure. I'm sure you must have seen some fruit, not maybe particularly in Indian fruit. You might see them in a few places in North India and in very colder countries. You have fruit, exotic fruit, red in color with multiple yellow dots. Strawberry? Yes, right. So that's how it looks. Does it look like a strawberry? It doesn't look like a strawberry, but this is called as a strawberry gallbladder. You have yellow dots with a pure red background, right? Perfect. So this is called as a strawberry gallbladder. Again, I don't want you to memorize things. You know it. You know gallbladder. Gallbladder is a vascular organ, and most of the mucosa, gallbladder is made of columnar epithelium. Every columnar epithelium mucosa will be red in color. We know that from Barrett's esophagus. So a red color mucosa with multiple yellow dots, we call it strawberry gallbladder. And in microscopy, look at this. This epithelium of the gallbladder. This is again the microscopy of the gallbladder. It's cholesterol, it's fat. Can I say that this entire thing is clear areas? It's completely clear, right? Kind of clear. All of these are fat accumulation inside the macrophages, right? Perfect. So we call this disease an cholesterolosis. Cholesterolosis is a form of chronic cholecystitis where you have fat accumulation in the gallbladder mucosa in the microscopy as well as in the gross. It's not exactly fat, the cholesterol esters, that's why we call them cholesterolosis, right? So fatty liver is simple, triglycerides, and in cholesterol esters, if you have the same appearance in a blood vessel, atherosclerosis. Same appearance in a skin or a tendon, xanthoma xanthelismus. That's it, right? That's my first intracellular accumulation, the clear one, which is fat. The second guy, I'm going to talk about protein and glycogen together. I'll tell you why I want to talk it together. Because there is one place where you need to know the difference between the diagnosis. I'll talk about protein first, little bit about glycogen, and then we'll combine as well. Fine. What's the color of protein in microscopy? Pink in color, right? I can have deposits of protein inside the cell as well as outside the cell. It can be anything. It's pink in color, that's all. There are multiple examples of pink color protein deposit, right? So protein accumulation, anywhere when there's protein accumulation, protein is going to be pink color protein. And first, you must have heard about proximal collimated tubule, right? What's the function of PCT? The function of PCT is to reabsorb, right? That's a function of PCT. Simple. So can I say in a normal proximal convoluted tubule also, I'll have protein reabsorption droplets because it reabsorbs everything, right? In a normal PCT, proximal convoluted tubule, you will see reabsorption droplets of protein. Okay, you'll have reabsorption droplets of protein for sure, right? Not just protein. If it's more, it can be more accumulation, also less accumulation. We'll see when there's more or less when you come to kidney. I'm just saying it will be present here, that's all, right? What is the function of plasma cell? What's the function of plasma cell? A very simple question. Function of plasma cell? Production of antibodies, right? Can I say antibodies are also proteins? They are also proteins, right? Perfect, that's all. So plasma cell, when they produce excess antibodies, let's say a very chronic infection, kind of producing antibodies more and more and more again and again. So this excess antibodies can be seen in the cytoplasm of plasma cell like an accumulation. It's an accumulation, right? This excess antibody, when it's seen in the cytoplasm, we have a term called as Russell body. So Russell body is nothing but excess antibody production by the plasma protein seen in chronic inflammation. So whenever there is more amount of plasma protein division, I can see Russell body. That's all. It's very simple, right? Third, And just using few examples, what Robbins talks about, that's all. You have lots of misfolded protein defects. Even in apoptosis, we read them, right? They have a malformed protein. It stresses the endoplasmic reticulum and causes apoptosis. One of the classical diseases, alpha 1 antitrypsin. Okay? Alpha 1 antitrypsin is one of the classical malformed proteins. It will reduce the transport and lots of them will have. So in alpha 1 antitrypsin, you will have proteins accumulating in the liver. This might little bit go above the head, these examples, but just remember them when we come to different individual topics in systemic pathology. We'll use this to understand them, right? Protein accumulation in liver happens in alpha 1 antitrypsin deficiency, right? Um, Normal cell, any normal cell, it's pink in color, right? It's made of few proteins called as cytoskeletal proteins. So when these cytoskeletal proteins are damaged, they form an abnormal accumulation, right? So when you have an accumulation of cytoskeletal proteins, I'll give you an example which we will read in future also for sure. That also will be pink in color. The best example for this is when we come to alcoholic liver disease, or some of you might have read this also if you're in the second half of your second year. There's a disease, there's a symptom or sign called as Mallory-Hyland body or Mallory-Denk body. Have you heard them? In alcoholic liver disease, we have something called as Mallory-Denk body or Mallory-Hyland body. Some of you might have heard them, right? So Mallory-Denk body is nothing but abnormal cytoskeletal protein, abnormal cytokeratin, that's all. So alcohol destroys the cytokeratin and accumulates them inside a cell, right? This is an example for an abnormal cytokeratin. I'm just giving you an example. So any abnormal cytoskeletal protein, when it's accumulated, it gives pink in color. That's the ultimate funda, wherever it is, right? Now let's take the second guy, which is pink in color, glycogen. So glycogen also mostly is pink in color. One important thing, and I'm sure in your biochemistry you must have struggled a lot to remember the table, the von Geerks, McArdles, and lots of them, right? So in case of a glycogen storage disorder is where it becomes important for me. In all the glycogen storage disorder, obviously I'll have pink proteins. And can I say glycogen storage disorder will affect the liver? It will definitely affect the liver, right? It will definitely affect the liver. This is where I have a concern, right? If you can remember the examples, remember. If you can't, just remember what I'm going to say from now. That is very, very important because that has an application value, right? So I'm having a pink color deposit in liver, which can be glycogen, and at the same time, I'm having a disease which can cause a pink color deposit in liver, which can be due to protein. So as a pathologist, can I differentiate this pink color from this pink color? I can't. So if I can't differentiate them in a biopsy, in a normal routine stain, what do I need? Our template is simple, right? We use simple templates and we learn a lot. We use special stains. Perfect. So we have landed up in a scenario in a liver biopsy. There's a possibility of two guys to accumulate and both of them are pink in color. One guy is your glycogen, which is also pink in color. The other guy is a protein, which is also pink in color. Right? Perfect. Our thing is simple. I need to have a stain because I cannot identify them on a routine light microscopy. I need a special stain. And we use a special stain. The same stain what we use for Barrett's esophagus, PAS, right? So we did a PAS stain. PAS stands for periodic acid shift. Once we did PAS, what happened was PAS was positive for glycogen. Like I was happy. But unfortunately, PAS was positive for protein also, which means kidney reabsorption in your proximal converter tubule will be positive for PAS. The cytoskeleton Mallory-Hyland, Mallory-Denk will be positive for PAS. Antibodies of plasma cell, the Russell body, will be positive for PAS, right? So protein is also positive, glycogen is also positive. What happens is I'm stuck. I'm back to the ground zero. I did a stain, but again both are positive. So let's say modify it, and let's modify it. So what we did was we added an enzyme. The enzyme is called as diastase. Diastase is a saccharidase. It destroys saccharides. If it destroys saccharides, which of these two will it destroy? Glycogen or protein? Comment just G or P. It's a saccharidase and I'm adding it to them slide, right? So here it will digest glycogen. Obviously, it's a saccharidase, it will digest glycogen. Glycogen is a complex sugar, complex saccharide, right? So diastase will have no effect on protein. Am I right in calling that? It has no effect on protein and it will digest glycogen for sure. Perfect? Perfect. So now what I do is, after doing this diastase addition, I'm going to do one more thing. I will repeat PAS. Okay, listen carefully with this an answer. After doing diastase digestion, I repeat the PAS. When I repeat the PAS, in glycogen, I have added diastase, which has destroyed digested glycogen. When I do PAS again, will it be positive or negative? There's no glycogen now. It's been destroyed. It's been digested. It will become perfect. It will become negative, right? Because there's nothing there. The diastase has digested that, right? It becomes negative. But on the other hand, your protein will still be positive. Clear on this? Any doubts till now? No doubts? We had both of them are pink in color. I did PS, both are positive. I added diastase with digested glycogen. Then I repeated PAS. Since glycogen is being digested already, it becomes negative now. Since glycogen is not, diastase is not having any effect on protein, it's still positive there. Perfect? Here. Now, we are going to derive a terminology. I want you to remember this terminology. If you don't remember this chart, that's okay completely. But please remember the terminology. So whenever you have any questions from now onwards which says PAS positive, diastase sensitive, which means it was sensitive to diastase digestion, which means I'm talking about glycogen. I'll tell you why this is important and how we are going to use it. That's very, very important, right? So here I use the term PAS positive and I call them diastase resistant. It is resistant to diastase digestion. If I call it resistant to diastase digestion, it is nothing but protein accumulation. One of them is protein accumulation. Other words, I can say it is not glycogen. That's more than enough for me, right? Right? Clear till this? Why I want to know this is, let's say I'm giving you an history of some liver disease. See, these are all facts. I have to make a case scenario out of it. 10-year-old kid with hepatomegaly, altered liver enzyme levels, liver biopsy was done, and the liver shows lots of PAS positive, diastase sensitive substance. My diagnosis becomes von Gil's disease, the glycogen storage disorder type 1, which will affect the liver. And it will be seen in children only. If it is diastase resistant, it's a protein, my diagnosis becomes alpha 1 antitrypsin deficiency. Right? So your diagnosis alters with just these terms. So these are the terms which will come in an exam as clinching clues. You know this, you can apply that for sure. Fine. So let's say how to apply this even more. See, I gave you one example. It's a fact. Don't read it as a fact. It's a clue for me. I can use it in multiple places. Let's say I'm just giving random example. 5-year-old kid, not growing. I'm having there is hepatomegaly, and it's PAS positive, diastase sensitive. I'm writing DS for diastase sensitive. My diagnosis, like I said, it's von Gier's disease because I know it's in glycogen and it's in glycogen storage disorder, right? Let me give you one more example. A 2-year-old kid died, has an cardiac failure and died. And after that, we had done a post-mortem, heart biopsy was taken. That showed PAS positive substance, diastase sensitive. Can anyone tell me the diagnosis? See, this is application. I have a fact. I can apply and create n number of MCQs. Fact is simple, glycogen. Yes, diastase sensitive. That is your perfect. That could be your Pompey's disease. Because I am sure you must have read in your biochemistry The Pompe's disease, glycogen storage disorder type 2, involves your cardiac muscle. So that's what integration means. You already know a little bit of thing. I'm adding one more fact here. Once I add one more fact, then automatically I make a beautiful disease out of it. I can give a history saying that again, a 5-year-old kid not able to do exercise, getting very tired. Muscle biopsy shows PAS positive, diastase sensitive, McArdle syndrome, muscle phosphorylase. Facts. This is one clue. I create a clinical scenario. So whatever exam it is, NEET or NEXT or FMG, USMLE, whatever is in the world, be strong in first year. You will ace every exam. I have a beautiful first year. I add my concepts the second year. Then I see patients in real life. I come to diagnosis. That's the only goal for you, and you will do it beautifully, right? So I can create n number of questions out of it. Same with protein. Like I said, I can create a question for this saying resorption droplets, PAS positive disease resistant, protein. Same for this, Russell body, multiple myeloma, it's a neoplasm of plasma cell, right? Positive, I can say, right? So I have given you a fact and I can use it everywhere. Don't forget these two. These two are very, very important for us, and I want you to remember that. Fine. Is it clear? Perfect. And this is how PAS positivity looks. Whenever PAS is positive, you have a magenta color. If you're able to appreciate magenta, great. Otherwise, call it dark pink color. That's all. Okay. Its magenta color is the positive color for PAS. All these are PAS positive structures. Okay. Fine. Perfect. So that's about my protein glycogen. There's one more guy in the pink color, which is hyaline. I'm not wanting you to remember anything in hyaline, but just remember this term. I will use a term hyaline when something is pink in color, but not made of a single substance, or I don't know what it is made of. Okay? It's not made of a single substance. I'm not sure of the composition. Then I call it an hyaline, right? I just want you to remember this. That's enough. I'll tell why I want you to remember this, right? Before I knew Mallory Denk bodies, it is made of cytokeratin. I used a Mallory hyaline bodies because I don't know what it is made of. I need to know what it is made of. When I know, I will change the name. Otherwise, I will use term hyaline. In your physiology, have you heard about a disease called as hyaline membrane disease? By any chance? Premature kids, lung problem, surfactant problem, hyaline membrane. I don't know what it's made of because that hyaline membrane is made of more than one substance, more dead cell, more protein, everything is there. So I cannot say the pink color is due to this, right? So if anything is pink in color, just remember this. I'm not sure of what it is made of. I use the term hyaline, right? One of the classical examples is hyaline membrane disease. That's pink color. A composition is multiple, complex composition. I don't know what it is made of, right? Perfect. So that's where I use the term hyaline, right? Perfect. But that's enough for hyaline. In Robbins, if you look at hyaline accumulation, they'll use the same thing. Russell body is hyaline. Everything is hyaline. Like it's pink in color, I call it hyaline. That's all. It's a template. That's it. Fine. Okay. I'm not going to talk much about hyaline then. The next thing is your pigment. Type 2 pneumocyte produces a factor, right? Next is your pigment. Pigments are beautiful. You can divide pigments grossly into two major things, right? Two major classification. It can be exogenous pigment and it can be endogenous pigment. Okay, we have exogenous and we have endogenous pigment. Exogenous coming from outside the body, endogenous something from inside the body, right? Exogenous pigment has only two classical examples. One is coal. We inhale carbon particle. We have lots of occupational lung disease, right? You must have heard about pneumoconiosis, lung problems, coal workers pneumoconiosis, right? That's a coal problem. It's inhaled from outside. Second thing which can be pigment is tattoo. Any of you guys have tattoo? No tattoo? It's okay once in a while to have fun, it's fine. But if you're having a tattoo, or if any of your friends and family members are wanting to get your suggestion for a tattoo, the only problem with the tattoo is go with a proper needle. Because the needle can carry diseases. Tattoo is not my problem. The needle in which tattoo is done is a problem. You have to know how to advise for that. Fine. Coal and tattoo are something which comes outside from the body. Tattoo based on the ink. Blue color. That's all. Pink. And I have lots of colors of tattoo, right? That pigment will be there. Fine. So these are the only two things which can be coming from outside the body. Rest every pigment is endogenous. And only this pigment will be black in color. Exogenous pigment will be black in color. Tattoo, common color tattoo is black only. Black ink of tattoo, right? Every exogenous is going to be black in color. But endogenous, every damn endogenous pigment is going to be only brown in color. What's the color of melanin? Melanin color, black or brown? This is a very simple question, right? Melanin? You must be wondering black in color, right? Hair. You look at a hair, black in color, melanin, right? No, melanin is brown in color. Everything which is there inside the body is brown in color, nothing is black in color. You must be question, why is my hair black? Why is your hair black? The reason is the density. It's very dense melanin which gives black color. It's always brown color. Melanin microscopy is brown. Foreigners called us brown people, right? When it's very, very dense, it becomes black in color. Otherwise, melanin is brown in color, right? Okay. There are everything in endogenous is brown in color. And right, 4 things which are important here. Melanin is brown in color. We already heard this person. We already read about this person. Lipofuscin. We did read, right? In the atrophy. Brown atrophy of heart, right? Lipofuscin is brown in color. There are 2 more guys which is brown in color. Iron. Right? Iron in the form of be it ferritin or hemosiderin, both of them. But I'm considering only hemosiderin because ferritin is physiological storage of iron. I'm not worried about physiology. It's normally present, that doesn't matter. The other guy which is brown in color is copper. Okay. Copper is also brown in color. Fine. So these are the 4 things which can be brown in color, and all of them can be seen inside my body. Now our concern is very simple. I have 4 guys which are brown in color. So as a simple pathologist, can I differentiate what it is based on light microscopy? Can't. If you can't, what do we need? Special stain, that's all. So you will be fed up with me. I have like 10 points. I use the same 10 points. I've used the same 10 points throughout the entire pathology. Application is more important. Just 10 points is enough for you to ace pathology. Fine. Same special stain is what I want. I want clues for diagnosis. Now we'll first compare melanin and lipofuscin. Then we'll compare your iron and copper. I'm differing the comparison because both melanin and lipofuscin are more or less physiological, not pathological. But hemosiderin and copper accumulation is always pathological, right? Perfect. The first thing, this is there in one of your competencies in your exam also, the pigments, right? So melanin and your lipofuscin. If you remember lipofuscin in atrophy, we learned about atrophy, right? That time you definitely must have learned lipofuscin. What is the location? I showed you lipofuscin in a cardiac muscle also. The location. Because lipofuscin is from lysosomes, yeah, on either sides of the nucleus, right? Perfect. The first and the most important thing is the location for me. They are paranuclear location. Whenever I have a cell with lipofuscin, there will be paranuclear. Let's say this is a cell, this is my nucleus. Lipofuscin will always be here, be paranuclear only, right? Okay. But melanin on the other hand is it will be diffuse. It will be diffuse, but it will be seen in the melanocytes only. Not every cell will have melanin. Only the melanocytes and melanophages will have melanin. Melanocytes is seen in skin, predominantly skin and hair follicles, right? So lipofuscin also has a stain, but I don't want you to remember the stain. The paranuclear location is more than enough, but there will be clues. Clues for lipofuscin: aging. Old age will have more lipofuscin accumulation, or any form of cell injury or cell damage. Whenever is an aging cell injured cell, will definitely have this, right? Next for melanin. I have a beautiful stain for melanin. Not so beautiful, but I want you to know the name because one of your competencies says that you have to differentiate melanin stain. You have to learn the melanin stain also. I don't know who created the competency. Unfortunate. I'll tell you why it's unfortunate. The stain here is Mason Fontana. Okay? It's a Mason Fontana stain. This came once in an exam also. I wish our seniors were more logical than just going textbook wise. Mason Fontana stains melanin for sure, but I don't want a stain in microscopy to identify my skin melanin, right? Skin will have melanin. Every normal human being knows that. When it's a melanoma, clinically I'll have a pigmented lesion. I know it's melanin for sure. Then why do I need a stain? That's my first question. Second, Mason Fontana stains melanin brown to black in color. Already it was brown in color. I identified a stain. I'm making my young doctors remember the stain and saying that that also will stain it brown and black in color, right? But it's there in your competency. It has come in an exam. Remember, there's a stain for melanin called as Mason Fontana. The utility in real life is almost nil. So it means after exam you can forget it. Even before that you'll forget it, right? Next guy is the other two. Hemosiderin and your copper. Like I said, ferritin is also a storage form of iron, and I'm not worried about ferritin because ferritin is physiological, which is there in the duodenal epithelial cells. It's not required for me at all. Only the pathological one is required. Wherever you see hemosiderin, it's almost always pathological iron deposit only. It's not physiological at all. Some problem is there only then hemosiderin deposits. Can anyone tell me which disease will have copper deposition? Anything? Anyone? Which disease will have copper deposition? I'm sure quite a few of you guys know it. Have you heard about a disease called Wilson's disease? Wilson's disease, you'll have copper deposit, right? It's an excess copper deposit. It can be seen in your eyes, liver. You must have heard them for sure. In your biochemistry, copper metabolism, they must have taught you at least the name of the disease, right? In hemosiderin, I have a disease called as hemochromatosis. I'm just giving you basic diseases. The hemochromatosis also affects my liver. Wilson also affects my liver. In biopsy, both of them will be brown in color. So I have to know the stains, right? I have to know the stains, right? Otherwise, I cannot survive it. The stain for iron is Pearl's Prussian blue. Okay, the stain for iron, like the name says, it will stain the iron blue in color. If it's positive, it will be blue in color. That's all. Okay, perfect. ATP 7B for Wilson, right? Great. So in Wilson's disease, which is a copper accumulation, the stain for copper, there are many stains for copper. At least remember two guys: rhodamine and orsine. Personally, I like orsine stain a lot because it's very good stain for diagnosis, right? To diagnose Wilson cases, orsine helps a lot. It's easy to do and it's very the contrast is very clear, right? But in an exam they say rhodamine, it's rhodamine. These are two stains for your Wilson disease. Again, the utility of stain is simple. Both of them, hemochromatosis and Wilson, both of them are inherited disorder. Let's say 50-year-old, like the 15, 20-year-old person has a liver failure. You take a biopsy, brown color deposit. Pulse positive, hemochromatosis. Orsine positive, Wilson's disease. The utility. Same history it will be. Only one difference will be the pulse. Same like what we saw for PAS, test sensitive and test resistant, right? All these are facts. I want you to use the facts to apply in a future thing, right? And also remember this is very important. The pearl stain or Prussian blue stain will not stain ferritin. So whatever pearl stains, it's always hemosiderin. It will never ever stain ferritin. Remember that. It's always only stains hemosiderin, right? That's how a pearl is made for. It picks up only pathological form of iron. It's not only in hemochromatosis. We will use these pearls in multiple places. When a bone marrow, normal bone marrow, is having no pearls, iron deficiency anemia. Having more pearls, sideroblastic anemia. I have multiple use of pearls. I'm just telling you one use here, which is hemochromatosis, right? That's all. Okay. And then there's a liver biopsy. Don't worry, you will not be asked you to find what biopsy it is. It will be there in the question or a history search of liver failure, which means a liver biopsy. You have lots of these brown color pigments. It's a very low power image, so it's a bit difficult to pick up the color. But there's something wrong. Some color is there, right? Brown color, and this is how it will be positive in pulse stain. It's definitely pulse positive. Wherever I see the brown color, I'm having the pulse positivity, right? So that's how it looks in hemochromatosis, right? Okay. That's with the pigments. I'm not going to take calcium for now. We'll do calcium tomorrow because I want you to have a fresh brain for calcium. And I know 2 hours is a bit of stretch. Your brain gets exhausted, right? So what we'll be doing tomorrow is we'll be completing the first chapter. We'll take autophagy. We'll do the other forms of cell death: necroptosis, pyroptosis, ferroptosis. We'll do this calcification and aging, right? Cellular aging. These are 4 topics left, and I'm sure definitely we can cover that in tomorrow 2 hours. Fine. If you have any doubts, do let me know. And obviously, I'll have some MCQs for tomorrow because we have not discussed MCQs today. We just read the theory. Read this theory tomorrow. We'll apply as MCQs at the start, and then we'll go over the rest of them. Fine. Okay. Any doubts? If not, I'll call it a day. I'll try to finish mostly on time. If I exceed by 5 or 10 minutes, don't mind much. Fine. Okay. If there are no doubts, can you call it a day? So thank you for your time. Thank you for your patient listening and answering as well. We'll learn more together. There are very few things. We'll learn more together. Santa is a good question. See, what happens is, see, when they know, let's say I know a disease, right? I know it's a hemochromatosis, right? I know it's an iron. So what happens is, in chemistry, all these are chemical stains, right? In chemistry, I already have lots of stains, which I know particularly, okay, this stains iron, this stains this. So I use a combination of that. I come up with a technique, I master the technique, I make it perfect, then I call it Pearl Expression stain, right? It's mostly like trial and error. The method is trial and error, but the basic information is already there with us. Thank you. Thank you, everyone. If there are no more queries, we'll call it a day. If you have any queries, no, you ask, like, any query, any doubt is worthwhile. I'll definitely answer most of your doubts. If I know, if I don't know, I will read and come and I'll answer the next day. I have no shame in admitting to any of my colleagues. You're my colleagues, you're not my students, and I don't know. That's very important to admit in medical science. But science is very big. We are very tiny, right? I know a little bit of it. If you have any more doubt, we'll learn more together. Fine. Thank you for your time. See you soon. Bye bye.